Today, I'm talking to Anna Swan, who works as a scrub nurse and the operating theatre. What a scrub nurse is exactly and where the name comes from. Sure. Well, perioperative nurse is the correct term, of course, but basically we're all familiar with the notion of scrubbing in, you've seen surgeons doing it. It's not just washing your hands. It is doing that cleaning to ensure you're complete. Sterile before you go anywhere near the patient or the surgical instruments, but the name scrub nurse doesn't quite capture the full role. I mean, basically your job's to prepare the operating room for surgery. You lay out the instruments, hung them to the surgeon when asked, and you're also responsible for monitoring the patient. So we are like the bridge between the surgical team and everyone else who's supporting the patient. So, how did you first get into this type of nursing? I remember one of my most formative experiences as a student nurse was shadowing a perioperative nurse in theatre. I had to scrub up too, and I was expected to lend a hand because they didn't want somebody just standing around in the way. It was all new to me and I was worried how I'd react. I was fine around blood, but I'd never seen a wound being created before it. The 30-minute hernia up, so nothing special, but it left a deep impression on me. Then later, when I reached the stage in my career where I was up for a challenge, that image came back to me. And what sort of background do you need to go into this kind of nursing? Well, you can do specialist courses, but I think what's crucial is having a fair amount of nursing experience, particularly in critical care settings. That was true of me. And there's really no substitute for that. To be honest, the job wouldn't suit everybody. The hours can be grueling and the work's very demanding, that you can't just pop out to the bathroom or have a snack when you feel like it. And you're stuck in a small room with some quite strong personalities, who are also under pressure. So, it's a very intense environment, but also a very rewarding one. And what skills does it? For well, basically every second counts. You've got to be very efficient and able to think ahead and get things organized, what needs doing immediately, what can wait a few moments, what you need to do now. Because you might not get the chance later. And so on. I mean, that's the kind of thing. You can train somebody for up to a point, but to do it well, you've got to be in the mindset to start with. Attention to detail is crucial. If that's not how you are, then you're not going to be right for the job. You have to be there, mentally, 100%, as well as physically, and I discussed the idea of the team is really important in theatre. Indeed. It's got to be part of the system. I mean, especially when you're on call, you never know who you're going to be working with for an operating theatre to run smoothly. There's got to be clear communication and coordination between everyone concerned, because it's the collaboration within the team that keeps patients alive in my hospital to promote team spirit. We set great store by meetings, at the preoperative briefing, of course, but also meetings to discuss issues and generate new ideas as a nurse. It's great to feel that your voice counts, and that's not always the case in medicine. So for me, that's a big plus. We also take opportunities to debrief tough after difficult events. I mean, that's crucial too. And what about the interactions with the patients? Well, some people have their idea that in the operating theatre, you're going to be having just mechanistic interventions on patients who are in no position to respond or interact with the nurse, that you're just providing support to the surgeon and the anaesthetist. But these days theatre nurses are required to have a holistic, patient-centered approach to care, and this extends beyond the period of the patient's actual surgical experience. The preoperative visitings become the norm, so that patients see a familiar face when they come in for treatment, and this can really reduce stress levels on the day for the patient. For me, this is a really positive development, and I'm always keen to take on that role. Good morning. My name is Graham Holder. I'm a junior doctor here at the hospital. The subjects of my presentation today is hand transplants. I'm not a specialist in this area and I have no direct experience of it. But I've always found it fascinating, and I'd like to share my interest in it with you. So, first of all, what is a hand transplant? And why is it better than prosthesis? Well, it's a type of a CTA. That's a composite tissue allotransplantation in which skin, fat, muscle and nerve bone are all transferred from one person to another today. It's largely been used to treat patients with both functional and aesthetic deficits that can't be dealt with by conventional methods. But this is changing. The mainstay of treatment for amputated limbs has long been prosthesis, but patients often, because they only provide limited mobility and function, and they can be uncomfortable in theory at least, transplanting a complete part. should give much better results than even the most advanced prosthetic technology. So more and more upper limb transplants being performed around the world every year. And this is largely thanks to new and more powerful immune suppressive drugs. The strategies in use have been derived from the experience of transplanting organs, especially kidneys. And this is also informed the choice of drugs. Slightly higher amounts of immune suppression are used with a potent induction followed by a low-dose maintenance regime. This regime can be supplemented by short courses of intensive therapy to overcome any episode of acute rejection. The survival rates of both patients and grafts under this regimen outperforms that for all other transplants. That's actually pretty impressive. At least one episode of rejection is recorded in 90% of cases. However, despite the immune suppressive protocol, and this is much higher than with kidney transplants. One reason for this is that hand transplantation represents a visible graft. That means you can make an immediate diagnosis of rejection based on minor changes in skin appearance, even though this has to be confirmed by a biopsy. If patients adhere to the regime. However, rejection is generally reversible. One of the challenges of hand transplantation is to achieve the delicate balance that prevents rejection, whilst at the same time protecting patients from the direct toxicity of the medicament, but this seems to be working. And infection is actually the communist's complication. So, what happens during a hand transplant operation? It's a 6-hour procedure, which involves 2 separate surgical teams. One, removing the hand from the donor, and the other working with the recipient. Bones are joined with titanium plates and screws. As with other bone grafts, they should eventually heal together, but the plates are left in to ensure stability. Surgeons then connect key muscles and tendons. Before tiny blood vessels are connected using surgical microscopes, 3 major nerves are then attached, followed by large and small veins. Once blood is circulating, the recipient begins to feel the new hand. A recent case attracted a lot of interest in the UK. It was a bilateral transplant for a man who lost both hands in an accident at work. Now, bilateral transplants aren't so uncommon. But what made the case particularly noteworthy was the fact that he still had both his thumbs but not the rest of his hands. So it wasn't a transplant performed at the wrist as is usually the case, but in the substance of both arms. Nonetheless, immediately afterwards, he managed to gain some movements in his donor hands and has since improved dramatically indeed. Just 9 months after the procedure, he was able to write a thank you letter to the surgeon. His recovery experience mirrors that of most transplant patients. The incredible thing about him is the speed at which he's gained that functionality. So, what about donors? One of the challenges of hand transplantation is that the hands not only have to fit in, logically. They also have to look right. Because they're going to be on view, an issue that doesn't arise with internal organs that makes the job of finding an appropriate donor even harder. In any case, because home transplantation is rather unusual, people have been slow to donate, and they've been occasions when surgeons had to ask for a donation when somebody's offered other organs, but not specifically the hands. And that's a really difficult thing to negotiate with next of kin at the time of death. Transplant program is now established and it's becoming mature. It'll be nice to think that hand transplants could become as routine as kidney transplants.